Hi everybody, I'm Susan Eichorst, physician assistant here at Atagi Aesthetics. Thanks for joining me. I practice medical wellness and hormone balancing with Dr. Tanya Atagi, and today we're going to take part in part 2 of our Facebook Live series, Spring into Wellness. So today I'm going to talk about the differences between bioidentical hormone replacement therapy and traditional or synthetic hormone replacement therapy. There's a lot of discussion still going on out there about this. A lot of confusion from both practitioners to patients, patients reading on their own, getting back to their practitioners, and still not getting the information that they really are entitled to. So hopefully a little bit of this will make some sense for those of you that are interested in learning more about this. So first I just want to refresh, what is a hormone? So hormones are chemical messages that our body sends out to another part of the body via the bloodstream, picked up in other tissues, and then help the body activate or work more efficiently with these little messages. We know they wax and wane over time. Even during normal menstrual cycles they will go up and down. But we also know that they diminish in time as well, which then presents with symptoms of menopausal symptoms for women, sometimes as early as their 30s and 40s, but certainly well into their 50s. Typical symptoms are hot flashes, vaginal discomfort, urinary symptoms, moodiness, night sweats. These are pretty typical complaints from women that they will see their gynecologist about. So a little bit of back history with respect to hormone therapy. Back in 1930s, early 30s and into the early 40s, researchers discovered that they could extract a hormone that looked pretty similar to women's estrogen, called estrone, from first women's urine, and then secondly from pregnant mare's urine. And we still use this technique today in 2018 to make our Prempro, which is pregnant mare urine. That's what that name stands for, and that is our conjugated equine estrogen that women take for estrogen therapy, and it's an oral compound. We also added in the 1930s a synthetic form of progesterone called progestin, or MPA, stands for medroxyl progesterone acetate. And these are very typical compounds that are found in our traditional hormone replacement therapy and in our birth controls as well in different doses. This worked great for people because it did relieve hot flashes, vaginal dryness, much of the moodiness, skin tone, even mental clarity. But what we found over time is that the risks really started to present the longer women were on these medications. So in the 1990s, we really honed in on, hey, there really is a higher incidence of breast cancer. This was shown in the Women's Health Initiative that was started in the 1996 time frame, and then published studies in 1999, 2000, when the big alarms went off that we probably shouldn't keep women on these hormones for more than 5-6 years, get them through their menopausal complaints, and then take them off because the increased risk for breast cancer, especially with the progestin component, increased risk of blood clots and stroke because of the swallowing of the estrogen and our liver having to process that, causing a disruption in how we clot, and an increase in dementia, even though we had seen good cognitive stabilization for a lot of women, but long-term effects we found, these women are actually getting higher incidences of dementia versus women that don't use hormone replacement at all. About the same time back in the 30s, bioidentical hormones were also being discovered, much more utilized overseas in Western Europe, Australia, but somewhat here in the States too, but kind of fell out of vogue because of the pharmaceuticals bringing on the synthetic forms which were patentable, which they had the money to run some research studies on and the money to advertise to. And this is where most of our practitioners got their information, was from the drug companies themselves. So bioidentical hormones kind of fell by the wayside, aside from people that were using compounding pharmacies that mix these compounds up, potentially more osteopathic doctors or naturopaths, and people that were a little more forward thinking. And that brings us to where we are now, with kind of looking at how do we help women that are having menopausal symptoms, that are being either told you're not a candidate for hormone replacement therapy because of family history of breast cancer, personal history of a blood clot, or they're just not safe, and women being very discouraged at how they feel at 30, 40, 50, even into their 60s, and thinking this doesn't make sense, that this is how I need to age. So bioidenticals became kind of back in fashion, understanding that there's a few things that are very different about these compounds. First of all, the hormones I spoke of already are not truly hormones. They don't look like my estrogen under a microscope. The progestin certainly doesn't look like the progesterone that I used to make. They look close enough to fit in these receptors we talk about, turn them on enough to relieve some symptoms, but regrettably leave us with a lot of very detrimental side effects. Bioidentical hormones, on the other hand, they are man-made, they are synthesized, if you will, manufactured and extracted from plant sources, but the molecule itself that is the hormone looks exactly like the estrogen that my ovaries used to make. It looks exactly like the progesterone that my ovaries made in the past, and it looks exactly like the testosterone that our men make and women make a little bit of. So when that molecule fits in the hormone, our bodies can't really tell the difference. Did I make this or did somebody give this to me? And then it acts in a whole different fashion because it's acting as if it's a man-made substance. What that does for us is relieve these symptoms without having the same side effects that the synthetic hormones have. So we take into consideration the type of hormone, and then secondly, how do we deliver it? So with synthetic hormones, we swallow estrogen and we swallow progestin. With bioidentical hormones, we do not take estrogen orally because I don't want to disrupt the liver and have any risk for clotting or stroke. So we either use it as a troche, which is a little lozenge that sits in the cheek, right up in the gum line, and lets the absorption go right into the bloodstream through the mucosa of the mouth, much like a suppository. If you slip a suppository in a little baby's butt, they get the drug through the same mechanism, but just a little different area in the body. So a troche is one option. We also utilize creams. We utilize an oral form of natural progesterone, and many of us like that at bedtime because it can help with sleep. But the way that I have found seems to be the most effective for many, many of my patients is actually utilizing pellets, where the estrogen itself is put into a little hard pellet. Pellet is inserted into the fat part of the butt, little tissue in the buttocks, and then the absorption goes in more of a steady state into the bloodstream. These women usually describe much better levels of hormones. They usually last about 3 to 4 months, and then we repellet them again. But I am open to other aspects as long as they're bioidentical. The routes that can have for traditional medicine is the oral route I mentioned, which I do not recommend. There is a bioidentical type pharmaceutical brand patch, which can be appropriate for many women, but don't always provide the same support or relief as many women would desire. And then we can actually take a vaginal preparation and put it in the vagina, and there's a few of those formulations that are pharmaceutical as well, and are bioidentical and fine. Next piece of this puzzle is really the testing. So traditional medicine, you're having symptoms, you get given, either offered a birth control pill to help with regulate your period if they are getting pretty heavy, which they can when we start to lose some progesterone as time goes on, or one of the hormone replacement options that I earlier mentioned. It is unfortunately kind of a one-size-fits-all situation, so there aren't a lot of dosing options. There's a few with some of the hormones, but not as much as most of us would like, and certainly not as much in the oral form. Not that I endorse that, but that would be something at least my contemporaries would give. So we endorse having testing done before we do pelleting, or I do prescribe any estrogen. Traditionally, serum or blood test is appropriate for pellets and for the troches. If a woman is using creams or a patch, then we do want to check salivary levels to get accurate levels. And there is a way to also check urine levels as well. We don't generally do that in this office, but some practices will. Once we have testing, then we really want to know, where are these levels? So there's normal levels, and that's fine. But there may be optimal levels where a woman really feels a totally different set of circumstances, not just her hot flashes are relieved and her night sweats are relieved, but suddenly her cholesterol goes down because her estrogen is optimized. She feels that she has much better mental clarity, but also hopefully we've addressed some long-term dementia worries for her, because we have that estrogen in levels that her brain really recognizes that not only are her symptoms relieved, but that her brain is getting good estrogen levels for cognition and long-term health. So the dosing is really based on what's my patient's symptoms, because I really care about, are we getting symptom relief, not just where do your labs fall, but also where are the labs, so that can give us some guidance. Do we have some room to move up? Should we move down a little bit and get those levels really optimized? The next piece of all of this, though, is also testosterone. Testosterone gets pretty underrepresented, or it doesn't even get discussed for women. Women make testosterone. Men obviously make the lion's share of testosterone, but women absolutely make testosterone as well. Here's where normal levels get very confusing, because a normal level for a woman could be 2. It could also be 45, depending on the laboratory. It could go up to 82. But when we supplement women with testosterone, we're really looking for levels that not only help with symptoms, but are also very helpful for improving overall health. And sometimes that would mean a female level of over 200 in a blood test versus her normal level, which might be at 7. Now, having said that that's a normal level, that woman still may be complaining of decreased libido, decreased mental clarity, high levels of anxiety, just not getting good effective workouts or recoveries, and her level could be at the high end of that normal range. So really those normal levels don't give me a good interpretation of what is going on with the symptom profile for that female. So testosterone is also applied through either a troche. Some women will use creams, although I frequently see women who say their levels, or not even just their levels, their symptoms are not relieved with the creams that they've been using. And then that testosterone also can be administered through a pellet, just like an estrogen pellet is. What we find with raising levels of testosterone is we definitely see increased muscle mass, which increases energy. Frequently that woman will start to lean down over time, although that has to have some patience associated with it, because that can take 6, 9, 12 months before a real change in body habitus for some women. We definitely see increased mental focus and clarity with higher levels of testosterone. Big one for most women is they will actually gain their libido back, so they actually have a desire to have sexual relations and are able to stay present throughout that whole encounter. I frequently see decreased levels of anxiety for women when their testosterone levels are higher. We know that testosterone is cardioprotective and can be breast cancer protective as well. So really it's a whole compilation of hormone balancing that we talk about here. Estrogen and progesterone, very important, and testosterone, which is kind of the third piece of that puzzle for overall wellness. So just a really quick little brief recap. Hormone therapy certainly has some risks associated with it in general, with respect to that we are reintroducing estrogen that has been lost for a female. The beautiful part of this, though, is we know that we do not raise those risks of chronic disease with bioidentical hormones, so the risk for breast cancer for a female remains at the same level as it would as if she didn't do hormone balancing at all with bioidenticals, with the caveat that we may even have some protectiveness, because not only are we balancing hormones, but we are also recommending some supplements to help with good estrogen metabolism, and we'll talk a little bit more about the major component or the major supplement there called DIM next week. Many of my patients, once they get better balanced and feel good, actually then feel empowered to take it upon themselves to make some daily lifestyle habit changes that then improve their health, and all of that presents with lower risks of all chronic disease long term. So hopefully this was just a little bit of an overview for those that are interested. If you are interested in more personalized information, how this would pertain to you and your personal history, I would love to see you in the office, and just call and schedule an appointment for a consultation. Look forward to seeing you soon. Thanks.